Hey, everybody, welcome back to the Energy MD podcast. I'm so glad that you're here with me today. So, today we're going to be speaking with Jez Medinger. Let's talk about the live active virus theory. It's something, this idea that people who have long COVID still have live active virus. This is something that we've seen in our practice, where when we start using antivirals and whatnot, we do notice that people get better or they die off, they start killing the infection, they may get a little bit worse before they get better. What are your thoughts? What's the research that you've seen on this theory about that it's actually the virus is persisting?
So we currently have, just for context, sort of received wisdom at the moment suggests there are 7 possible causes of long COVID. Now, I suspect that we're probably going to find that actually a number of these are implicated more than necessarily just one, although it might be a tree with one of them at the top, which could be viral persistence. Let me just run through those 7 for context. So we have direct tissue damage, so organ damage as a result of the virus, autoimmunity, immune dysregulation, disruption of the microbiome, reactivated latent viruses like EBV, for example, viral debris, and then finally viral persistence. So when it comes to viral persistence, we've got, if you think of it like a game of Cluedo, we've kind of got all of these clues, but it's all kind of pointing towards Colonel Mustard in the billiard room, but we don't have the smoking gun just yet. So we've got things like viral DNA being shed for X number of months in a certain proportion of stool samples. We've got viral RNA being detected in gut biopsies. We've got subjects. We've got recent papers like Akiko Iwasaki and David Petrino's one finding T cell exhaustion. And T cell exhaustion is sort of a bit of circumstantial evidence suggesting that, well, why are they exhausted? Because we've still got persistent virus. So there's all of these things kicking around, which all seem to suggest that, and that's just 3 of dozens of bits of circumstantial evidence, which all seem to suggest that there may be persistent virus in the body. But right now, we don't know where it is exactly. It could be in a number of different places. I mean, the obvious places to start looking would be the guts, the lungs, things like the appendix, and then there may also be immune privileged sites as well. We just don't know if they're like in the eyeball or the testes, and until we start, or even potentially even in cerebrospinal fluid, so until we have, I mean, the way to do it, unfortunately, this isn't going to pass any ethics and is never going to happen because you can't do it. But if you suddenly had 20 long haulers die and you could just do full autopsy workups, the problem is that these biopsies you need to actually find the smoking gun, you can't do on live patients. So it's very, very difficult. We're only looking at what we've got in hamsters or what we've got in hospitalized people who subsequently die and then have autopsies, or what we might get from stool samples and things like that from living patients. So it's really, really difficult, but we're starting to get increasing amounts of evidence that points towards the fact that there is some remaining virus in the body somewhere, but we don't know exactly where it is yet.
Mm-hmm. Yeah, and that would explain a lot of those other studies and, triggering this aspect of the immune system causing hormonal dysfunction or whatever.
Yeah, absolutely. It would explain, if there were to be viral persistence, everything would fall into place.
Yeah. So then let's talk about current thinking around treatments. What are people, I mean, I'm practicing functional medicine. I'm kind of doing stuff over here and experimenting with the folks that I'm working with. But what does the data say? What have you gleaned from some of the data from the patient groups?
So there's a wide range of different kinds of treatments. So if we start off with the ones that your doctor might give you, then we can start off with something relatively simple like antihistamines. So H1 and H2 antihistamines do seem to be helpful for a large number of people. And there is some evidence to back this up. We've got a couple of small trials which have been published showing that they are effective with people with long COVID. For people who have POTS, so postural orthostatic tachycardia syndrome, which is a form of dysautonomia, then there is medication that can help a huge amount with that. So things like, beta blockers, ivabradine, midodrine, things like that your doctors can prescribe that can make a big difference. You may also find that if your symptoms flare, and so for me, I had a horrific skin inflammation at one point in my long COVID, and I was given some steroids, corticosteroids, and again, that helped significantly bring that flare down. There's an argument for trialing low-dose steroids in long COVID. I'd like to see that trial, but they will need to be done properly. There's also questions around, long-term use of steroids even at a low dose too. So, not ideal. Then we've also got all sorts of things that might be prescribed for symptomatic relief for whatever your symptom constellation is, because there will be various different things for headaches or for, itching, pruritus, or anything like that that can help you. So your doctor can help you with this stuff. There may not be a magic pill for long COVID, but you may find your doctor can significantly help you. You've also got things like conservative measures that your doctor might prescribe. So this would include things like increase your fluid intake. If you're dysautonomic, and especially if you're POTS, that can help a lot. Increase your salt intake. Again, that can help a lot if your blood pressure's all over the place and your heart rate's rocketing when you stand up. If your doctor so there are some doctors who are also going a little bit further than this. So we've got someone who your American audience will probably be familiar with, called Dr. Bruce Patterson. So he does a workup on your blood and looks at which of your cytokines are elevated, which are inflammatory markers of the immune system. And then one of the drugs that he often prescribes is Maverick, and there's another, he usually prescribes a statin like pravastatin as well. Some doctors will prescribe LDN, which is low-dose naltrexone. So this is a drug that would normally be done for opiates and opiate addiction, but it does have a surprise. Well, it seems like there's a proportion of long haulers who respond very well to it at a low dose in terms of it calming everything down, essentially. And then another thing as well, if you have a very sympathetic prescriber, they might put you on anticoagulation. Particularly if you've had blood slides done up that show some form of clotting. But again, this whole subject of microclotting is a huge thing that the patients are very excited about, but amongst the medical community, there has yet to be widespread consensus on what's going on this sort of microclotting side of things, or indeed thrombotic stuff generally in long COVID. Mm-hmm. But anticoagulation does seem to help a number of patients too. Beyond that, it's a long answer, but there's a lot, right? Because everybody has tried everything. You've got the invasive therapies, so things like apheresis. So this is happening in Germany, either plasma apheresis or HELP apheresis. People are also having NAD infusions. So NAD is one of the precursors of ATP, which is our body's sort of fundamental unit of energy. So people are having infusions of NAD. Monoclonal antibodies as well. Some people are reporting positive results from those. And then you've got a whole world of holistic stuff. So everything from cold water swimming to acupuncture to intermittent fasting to lymphatic massage, and onwards, Reiki and homeopathy. So it's a huge subject when it comes to treatments. And in terms of what have we got data for? Well, not a lot right now. Antihistamines is something we do have data for. I have a little bit of data too for a survey I did last year. And I looked at how long haulers responded to 3 different interventions that they had changed in the last month. So they'd either started taking supplements or they'd started taking niacin, vitamin B3, or they'd started taking started adopting a low or no histamine diet. And sometimes some of those groups coincided. So some of the people were taking niacin as well as starting a low histamine diet. What came out of this was that the low histamine diet was by far and away the most effective of these things. Supplements were no different from the control group. So like we would sort of expect, it's a bit of a lottery with supplements unless you manage to plug an existing deficiency that you didn't know you had. But the low histamine diet made a huge difference. And this would work for the same reasons the antihistamines work, which would be calming down this mast cell reaction that is one of the things that seems to be going on in long COVID. Why would niacin help? Well, again, this ties back into the metabolic side of things. So nicotinic acid, which is what niacin is one of the central precursors to make NAD+, which is how we generate ATP, which is energy. So there's a pretty strong theory, I think, that was published about a year ago now from some South African doctors, suggesting that some of the metabolic pathways that would normally happen, normally work in our body have been hijacked, and we end up using the wrong metabolic pathways, and that has all sorts of consequences on us. And we can start to compensate for some of that by supplementing with certain things, and the most important of those is nicotinic acid. So yes, the nicotinic acid. I looked at sort of p-values for statistical significance for both the low histamine diet and niacin, and they were both statistically significant with 0.0. I have to do this from memory. It's about 0.01, I think, for the niacin, and 0.0001 for the low histamine diet. So well below that 0.05 threshold. So very long answer. I tried to cover the whole enormous topic of long COVID treatment there.
You did great.
Thanks.
You know, the challenges that I have, and I think that a lot of patients have with the treatments that are available right now, is that essentially they're Band-Aids. You know, if the immune system is dysfunctional because of virus and leftover virus and immune dysfunction or whatever it is, right? You're taking these either their supplements or their medications or whatever, and they can mitigate symptoms and they can potentially allow you to get back to somewhat of a normal life. But the challenge is that it's not causing resolution, right? So
it's like whack-a-mole. All of these treatments are whack-a-mole, and you're not fundamentally taking the batteries out of the game. That's the problem.
And the treatments that I would say haven't been addressed or aren't being talked about in the mainstream media that a lot of me and my functional medicine colleagues are talking about is going, you know, directly after the virus, or is also looking at what are some of the other toxins that are present. You know, oftentimes we're seeing people who have mold, people who've had another virus, like you were talking about when you had glandular fever. You know, one of the studies, as you're aware of, 73% of people who have long COVID in one study also had Epstein-Barr virus, right? So what else is going on that's causing the immune system to be dysfunctional so that it actually can't take care of long COVID, right? What is actually happening there? So I would just kind of throw that in for people to think about. Does that make sense? Would that be a potential theory? Yeah.
Hugely. And mold is a massive one too. So what we're often finding is that any sort of slight intolerance or slight allergy or slight issue that you had before is just suddenly multiplied 100 times by COVID. So you may have been a little bit reactive to mold before, but it's never been a big problem. But now that tiny bit of mold in your house is destroying you. Right. You know, and it's not, and you wouldn't have connected the two because, like, well, I've always been here before. You know, so I haven't moved. So what's changed? Well, what's changed is long COVID, and now suddenly everything that wasn't a problem before is a problem.
Yeah, and we're even seeing people who lived in mold before, and now they're in a current home where they don't have mold exposure, but then all of a sudden now they've got a mold problem. So tell us, before we adjourn here, tell us about the Long COVID Handbook that's coming out in a month.
So this is quite exciting. So one of the issues I think that faces somebody who's developing long COVID now or has developed it recently, and they're suddenly hit with this, what the hell is this? What's going wrong with me? What can I take? What can I do? What shouldn't I do? How do I get help from my doctor? You know, you will have all of these questions, and you can put them into Google and see what the internet throws back at you, but you will get a whole world of conflicting advice. And it seems that there was a real need to have a singular resource that brought together everything that we had learnt in the last 2.5 years about long COVID into one place. So this combines everything that we've learned from the published science, whether that's, you know, in Nature and Cell and JAMA, or whether it's my patient-led research, which comes to it from a different kind of angle. And we've also got the perspective. So I co-write it with Professor Danny Altmann, who's a professor of immunology at Imperial College London. And between us, we sort of cover the clinical and academic side, and then from my side, the patient-led side, to sort of try and cover every aspect of the condition, from the hard science about what we think might be causing it to how you deal with your mental health when you're suffering with long COVID, and how you deal with your relationships, and and what the emotional journey is like when you are suffering with long COVID, because that first 12 months is going to be a roller coaster with more downs than ups, in terms of the way that it affects every part of your life in a way that people just don't really understand. And this is one of the hardest things, is how do you get people around you to understand? Because unless you've experienced a condition like this, it's very difficult. So I broke my pelvis about 18 months ago, and people immediately understood. It was a motorbike accident, 70 miles an hour, broken pelvis. Oh my God, are you okay? What can we do? It's a week in hospital. you know, it must be so awful. I'm like, yeah, it's pretty bad, but long COVID is 10 times worse. You know, I'd break my pelvis every 6 weeks on repeat rather than have long COVID continually. Because breaking my pelvis doesn't stop me drinking coffee or drinking tea. It doesn't mean that I can only eat like 3 foods. It doesn't stop me having a conversation with someone for more than 3 minutes because my brain goes to hell. It doesn't stop me writing an email or being able to read or being able to watch TV. All of this stuff with long COVID, poof, out the window. Every one of your faculties is affected. And unless people have had a condition like this, it's very difficult, you know, knowing what it's like. So one of the things the book also does is help you to help the people around you understand, to give you the support you need. And that's why also the patient perspective in a book about long COVID is so important, because, you know, as essential as the clinicians and the academics are in terms of pushing the boundaries forwards, research, when it's done properly, takes time. And in the meantime, you kind of need to have that sort of patient perspective of people who've gone through it to help you know how you can get through it too. So yeah, that's the purpose of the book. I'm very excited to share it with everyone.
Yeah, I'm excited to read it. I think that what you were talking about with like the mental health component is so incredibly important. You know, when we have people go through our programs, you know, we've got a mindset practice. So what do you do personally in order to be able to deal with some of the mental emotional stuff of this?
So one of the things I found is that in the same way that your autonomic system is like smashed, like I've been sort of sending it into the red the whole time before COVID, then COVID came along and suddenly it's like the whole engine basically just breaks, right? And suddenly the cogs are all just grinding and everything's a mess and it's sort of, you know, you've over revved it and it's exploded. Well, the same thing's kind of true for your emotional state as well. So a lot of people say the same thing. And certainly my experience is that you are just all over the place emotionally. So you are tipped over the edge into sort of that sort of emotional distress by things that wouldn't normally be that distressing. You are perpetually, I sort of look at my sort of emotions as like a pint glass, right? And normally, you know, sort of you've only got a little bit in there, and you can fill that pint up with like quite a pint glass up with quite a lot of stuff before it overflows, and you know, and you get overwhelmed. But actually, when you're suffering with long COVID, it's like it's perpetually about to overflow, and it doesn't take much. So trying to actually just manage your emotions in that sense when you're like that is really difficult. And for me, I find letting that emotion out to be absolutely key. So breath work, in particular, guided meditation, I find incredibly helpful for me on a couple of different levels. The first of which is that it's really good for calming down the autonomic system. And the second of which is that often it'll cue basically like 10 minutes of crying. And I'll just cry for 10 minutes and I'll just sob, and this emotion will just pour out of me. And a lot of it is grief and loss and frustration and anger and pain from not just prior trauma in the rest of my life, but also my health and the life I no longer have, right? You kind of have to grieve that. And if you don't, then you're just bottled up the whole time. So actually finding some way of releasing all of that emotion is hugely important. And after every time I've had one of those 10-minute sobs, it's horrible whilst you're doing it. It feels like, you know, vomiting when you're sick or something. It's horrible, but you feel better afterwards. It's cathartic. And that's certainly been my experience and the experience of other people I know with long COVID who have found whatever is right for them to be able to find that degree of emotional release. And that's been my best way of managing my mental health, because if I don't do that, I just get worse and worse, you know. And you know, I suffered with depression before, and oh my God, does long COVID like make that hard to deal with? You know, it turbocharges any depression you might have had kicking around the system. So you kind of really need to be on top of that in whatever way you can, because this sort of connection between mind and body, if you know, I'm sure you will understand this too, practicing functional medicine, it is real. And if you are in emotional distress to that level, it will not be doing your health any good, and it won't be doing your autonomic system any good either. So it is something that you have to deal with as part of looking after yourself physically too for long COVID.
Thank you so much for the beautiful vulnerability and sharing that with us. Jez, thanks so much for joining me today.
Thank you so much for your time. Thank you, Evan.